Thank you very much, Sarah. So we've had very excellent presentations throughout the past couple of days, giving an overview of what's happening technologically and in terms of communication. So I just want to, in a way, this kind of talk I hope, pulls this together a bit. So in 5 years ago, the 1,000 Genome Project was recognised as being a major advance, and in the UK we now have the 100,000 Genome Project, which I think is currently up about 70,000 genomes sequenced, supported by governments. We heard in previous talks that other governments are also supporting this kind of thing, and this is publicised and recognised by the general public because people have an interest in this kind of thing. They seem to have linked onto genomes. But there's a lot of other initiatives, some of which have been alluded to, some of which have not, which are being done by governments and other organisations, such as the Digital Agenda for Europe from the European Union, which is a 2020 initiative, and living healthy and ageing well. You have a task force on that for health and digital policies. You have IT for the future of medicine. You have things like a virtual liver, so people can explore what you can and cannot do with livers, for example. You have a virtual physiological human, which again was a Framework 7 initiative from the EU, which has become a virtual physiological human institute, which gives an opportunity to simulate effects. So we have quite a lot of efforts in that direction. And of course, we haven't actually mentioned, I don't think anybody's mentioned, the microbiome, but this is one of the other areas where there are advances which we probably hadn't thought of a few years ago. And it's also being picked up by the general public. So they are aware of this kind of thing. And of course, the other area they're particularly aware of in terms of genomics and genetics is things like oncotype IQ, which is being used in breast cancers and health services around the world. And in some countries, of course, this kind of technology is being promoted directly to the general public, to patients, and basically saying, ask your clinician to have this test done. So there's an education exercise, a publicity exercise, if you like, going forward with the general public. Because the other area is you can get your own genomics done to find out, well, whatever you want to find out. I mean, 23andMe was mentioned in one of the talks, and there are a number of other companies doing the same kind of thing. So you can find out about ethnicity. And find out whether you have your Scandinavian roots or you have an Indian heritage or whatever it might be. And with that comes an assessment of your clinical risk based on the sequencing that's being done. And of course, there's then an issue of, well, what does this actually mean? But this personalised area, which people have actually latched onto it, there's more to it than just genomics. And we've talked a lot about looking at laboratory tests, but looking at your cholesterol and your thyroid function, your diabetes, that's a personal engagement issue, as has been well illustrated by earlier talks. But of course, there is a sort of a view of the patient that the laboratory is basically a test tube of blood which disappears off, and their doctor does something with it, and the answer comes back. And at the risk of offending people, I would suggest that generally that's the laboratory view of the patient. Maybe not true of an audience like this, but one recognises the paternalistic nature of the care, that samples are collected and sent, and that the ownership of the information, the diagnosis and the monitoring actually resides with the clinicians. And as Pat has illustrated, patients often have a poor understanding of what the tests mean, perhaps because the information is not made available to them in a form which they can process. But of course, if you want to know something, the answer is go to the internet. So you can go on the internet and find out about health tests. And it may be quite attractive to do, self-testing. So this is just a website which says you can do all these different tests, including glucose, hepatitis, kidney function, cancer, cholesterol, for yourself. And people clearly do. I mean, this was a reaction from when I first started talking about this subject, which was in 2012 in Reykjavik. And this patient was speaking, and she said, "We went home and Googled. It was a fear of the unknown. We were scared." And you can understand that reaction. She wanted more information, and she went to where she thought the information would be. And of course, what we don't know was whether she got information that was correct. And having got the information, did it give her the answer that she wanted to know? There are various sites which will critique lab testing. This is a US site which publishes very regularly on a whole range of things. The worrying point about this one is the subheading underneath here is these are selected grants and other items to reduce medical errors, especially clinical laboratory errors, which I don't think we have any problem with that, but it does make you wonder about the veracity of perhaps some of the things that are being said. Of course, if you don't want to do self-test, you can go do internet testing, go online to a private clinic who may send you out some sampling devices and charge you a lot of money for what are actually quite simple tests. And of course, the progression of prices with more and more tests, as someone who's ill-informed, you would think, well, that must mean it's a better test. I should have all these tests, which of course, clearly you shouldn't. So again, there was a reference to where do patients get information from, and there was a study in Germany about 5 or 6 years ago now, where patients would ask their pharmacist, internet and print. Unfortunately, they didn't discriminate between internet and print information. 3/4, mobile apps, of which we'll hear more later today. Physician friends, we assume that they would probably be a reliable source. Television. So most of these are unvalidated sources of information, but they're of course this list actually reflects what the other speaker showed, that you go for what is available, what you know is possible. We've mentioned lab tests online UK, we've got plenty of plugs, because there's lab tests online in 13 languages around the world. This is the Romanian one, which is clearly a definitive source of information, giving good information on tests and common questions which are reliable because they are professionally mediated. There are also commercial sites like eSanté, which through advertisement is supported, but it gives the same kind of information within that country. There are government sites. This is the UK England NHS site, so it gives you some information, so polycystic ovary syndrome, and then a better explanation there. So again, an authoritative source. The difficulty for people looking at things on Google is, what's an authoritative source? How do you know that it's actually going to have valid information? There's no kite mark to say this is a good site, and that might be something we should be trying to promote, perhaps. But moving very briefly on to apps, I don't want to get into Snezana's presentation, but there are apps around which will tell you about normal lab reference values, come up with quite nice little graphs, recognise that there are different kinds of units, and it has a very high rating. So would you buy this? Yeah, it's free, so why wouldn't you? The question, of course, is how good is the information? And as I say, Snezana will be addressing that later on. So, yes, I mentioned, can you do the test yourself? And I referenced that private laboratory. So, this is a Google search. You can do a kidney test for £4 or so. A family health screen is only maybe £5.50, or a really good kidney test is £10. not the kind of tests we would do, not the kind of sampling we would do, and therefore there's going to be a problem with the results and what do you do with the information. And of course this kind of stuff is absolutely meat and drink to newspapers. And I was interested when Richard Fitton mentioned the fact that he used publicity to promote the patient awareness. I had a quick chat with him later on. We don't tend to publicise what we do in the media. We don't produce many press releases, and if we do, it may just be to national media. But of course, we've now got social media. You will find professional organisations that have Twitter accounts, which are really generally very tedious. And because what newspapers like is something which is slightly salacious and surprising and so on. So this sounds really great. A £2,000 test will predict every disease you'll ever have, which sounds, well, it'd be great if that was true. And I've never heard of this one again. So that's maybe 10 years ago, so presumably it didn't work. Perhaps it was something to do with Theranos, I'm not sure. Wrong one. But looking at a whole bunch of biomarkers, as we all know, you get irregularities. And if the patients are getting these kind of tests, they're going to worry about the result. Am I going to be in fear of my life? And the chair of the Royal College of General Practitioners in the UK, she says she's seen patients' lives turned upside down because they've been told they have a predisposition, so this is going back to the genomics thing, of having cancer, even though they've never developed the disease. And her opinion was, such scans are a waste, unethical and cruel. So these are, again, I don't think we need to go through these tests. But these kind of tests have been assessed by a consumer organisation in the UK. They assess everything from fridges to cars, but they've actually done some self-testing kits. And what they identified is perhaps no great surprise. I mean, people can do the tests. Usually they tell you how to do them reasonably well. But they comment that there's gaps in the information provided, the tests failing to mention factors that could affect the results and cause unnecessary worry. They found them difficult to use. The language was confusing. That's not necessarily because it was medical language, it was just the way it was expressed. The naming was incorrect, and there was false alarms and false reassurance. So, again, not recommended. But remember, this is for the general public's consumption. There is an awareness that tests can be done. It's just not an awareness of how they should be done best and how to get the best information. Some of the consumers said that the prostate test results would have led them not seek medical help. So that's a significant risk. The chief executive of this organisation, which is called WICH, observes that self-test health kits could be a useful tool, but the lack of clear information about how to use them could do more harm than good. And it goes on to say that as your general practitioner can do these tests anyway and can deal with the consequences, that really is the place that you should go. And a survey done in the University of Birmingham a few years ago found, I was quite staggered to find, there was 104 different types of tests available for self-testing, covering a whole range of conditions. They were generally worried well, and interestingly, there's a 2-to-1 male-female ratio, if you exclude pregnancy tests for obvious reasons. And he estimated there's about 7% of the population actually did these tests. And one of the issues that comes out of this is that this ratio may actually reflect worried well men, who we know men do not present necessarily as well as women with worrying symptoms, and they actually may just do the test first to kind of get reassurance, or perhaps to find out whether they should proceed. Commonest tests were for diabetes and cholesterol, followed by allergies and infection, with HIV being the commonest one. The general comment was that testers had worse health and based on BMI than the general population. So you could actually say that the worried unwell were using this approach. Now, we've heard a lot about what patients want, and Pat's covered this, so I just thought we'd maybe perhaps reinforce some of this. You expect to see a result. It's mine as a patient, not yours. I expect to be told what it means, what it means to me. I expect to see all my results whenever they are done, and I don't understand the problem. Of course, we had this discussion before coffee about, well, results should be readily available. Why wouldn't they be? And I don't know about other countries, but until not too very long ago, it was practice for general practitioners to say, well, come back in 2 weeks, which was giving them time to, for a self-correcting illness. But of course, it kind of got into the mindset, unfortunately, of the politicians, that this actually meant that the labs couldn't provide results immediately. And of course, as somebody said in the discussion yesterday about the kind of time frames that they responded to, that's typical time frames, I'm sure, for us all. And of course, the results have to be in my medical record. I definitely don't want to be patronised, and it's happened before. And I expect to have access to good quality information about my condition with my results. And I want ready access to my health professional. So all these things we've identified already. I need to know it as soon as possible so I can stop worrying. You're having a test, and I don't know how many people in this audience have actually had a worrying illness, but you do want to know as soon as you possibly can what the answer is. Now, I want my test at the minimum inconvenience, the quality will be good, and I expect it to be right. Of course you would say that, but when you think about some of the other tests that I've just been talking about, you couldn't guarantee that. But as an individual who's not professional, you wouldn't know whether that was true or not. If somebody says to you, you have a little van, I know Danielle goes on about a white van that she used to have outside her hospital, where they were doing point-of-care testing, they were not doing it properly, but because it looked professional, people communicated in a semi-professional way, people were reassured, but they were getting the wrong answers. One of the things you need to be is much more patient-centred. So if you're going to have access to a healthcare system, phlebotomy needs to be readily accessible, not bookable 2 weeks in advance. Everything to come back to them with the interpretation. And because one of the things you want is a decent patient record. And the electronic patient records, has again been evidenced over the past couple of days, are of very variable quality. The EU had a project called Sustains, which ran for a couple of years, 2012 to 2014 in Uppsala in Sweden. And the lessons learned from that helped roll out in other countries, including Estonia, Spain and Italy. And Sweden now has full access for all its population. Any Swedish people in the audience, you can correct me if I'm wrong. And my understanding is there's an uptake of about 1/3, which actually highlights an issue. Yes, the tool is there. It was something like the patient access we talked about for general practitioners earlier. But how do you get people to take up the opportunity to access this record? But then, of course, they maybe only access the record because they need to, rather than want to. There's a similar project called Decipher, which covers cross-border record access, and Petra talked about some of that yesterday. But of course we know, and one of the issues about cross-border and the issue about big data is all the things that are coming back to haunt us, like different units, traceability, and all these things which we've never really solved. So in 2003, there was an editorial in the BMJ which said, the good patient will, so this is looking forward, going back to the first lecture, I suppose, on predictions, will bring a list of questions and expects clear answers. Know they want to be involved in their health decisions and share them with their healthcare provider. Expect free access to their health records. Request and receive second opinions for major diagnosis decisions. And communicate electronically with the healthcare team. I think we can pretty well say we can tick all those boxes. This year there was another paper on the e-patient. So this is the person who's developed out of this. The e-patients use their own initiative. They participate in patient community networks where they inform each other about their diseases, are engaged with their healthcare. Their autonomy releases resources for non-e-patient support, which is an interesting aspect of the benefits of this kind of thing. And they have a hashtag, a group called We Are Not Waiting, which tells you where they're coming from. We want everything now and we want it right. I think GDPR has been done to death, so I won't cover that. But there is an element of, well, and this has been again alluded to, that people don't access results necessarily. Don't tell me I don't want to know. Why people don't want to access medical diagnostic information. And it seems to be related to the severity and untreatability, which perhaps what their perception, not necessarily a professional's perception, negatively associated with the willingness to undergo testing. And there was a question, is this true in chronic disease management? Because you actually know you've got a disease. So is there any benefit in not actually knowing how things are progressing? I mean, there is this element of, if I don't know it, I'm fine. But even if patients are told things, and note the word is told, what do they actually know? So in this study from a few years ago now, 99% of physicians had informed the hypercholesteremic patients of implications and targets. You actually do wonder about the 1%. 77 patients were satisfied with the information, although 18% claimed no information, and about a quarter knew that high cholesterol was associated with an MI, but only 35% thought they had achieved their target, yet the physicians are supposed to have told them what had happened. And this poor concordance is linked to lack of knowledge and possibly to lack of reinforcement, to be fair. So, Pat mentioned her time in the bookie shop placing bets on horses. And there is an element of how data is presented. So verbal data presented as fractions or verbally, generally percentages is better understood than the fractional data, and you have the different ways of expressing this. But the pictorial data is at least as good as verbal data and works better down at this end, where you have what be seen as more complex ways of expressing things. This is a well-known paper on numeracy and patient comprehension from the Annals of Internal Medicine, and I don't expect you to read it, but the essence of it was they had a numeracy test on patients, which they used to discriminate between numerate patients and innumerate patients. And what I took away from this was that essentially the way you present frequency is key to understanding. And without going into all the details, expressing it as a percentage, is marginally preferable in the numerate group and also in the innumerate group. And also the way data can be presented. I mean, this is the kind of stuff that we all love, but if you express it like that, it's much easier to understand, and it comes up to pretty much the same answer in terms of communication. Or you can use a pictogram. That's incredibly clear. You know it's going to be 5% because there's 100 people there, and it's very clear. So really, I mean, Holly's presentation really covered this in much better detail than I possibly could or even would want to. But really, there's a message there that the way we communicate verbally and even in writing, it really needs to undergo a revolution to ensure that people can comprehend things best. Informed decision making, I think we would all agree with that as a concept. And then there's this question of retention of information that you have, and this is a study on diabetics and the CHD risk. This is the actual risks here. So risks there, and understanding is along here. So that's the actual risk. This is what they thought of the 1, 5 and 10-year risks. The actual information was conveyed to them and it was reinforced. It fell, and for the 10-year risk it almost fell back to what it should be. But then, after a period, I think it was a year, it started creeping back up again. So it's all very well giving information, making sure people understand, but you actually do need to reinforce that information on a regular basis so they're actually grounded in reality rather than their perception. So, and this is the same kind of thing. I understand what the results mean. Well, over half the people in this study didn't. But as Holly mentioned about her own condition, you do understand your HbA1c much better because you're seeing that all the time. You know how that directly relates to you. And again, another study which reinforces this. This is old news. So, but some people look for tests for reassurance. That's part of the issue about the self-testing stuff as well. A systematic review found there's absolutely no evidence that reassurance is given by getting test results, which is slightly worrying. This is an old study where it was mailed, but the mailed written reports were sent to patients, but really the outcome was the important bit. 50% did not understand what it meant, again because of the presentation. They had unmet expectations. One assumes that they thought they were going to be better than they were, and when they weren't, there was negative emotional responses. So there's also this issue of, well, there's an element of support needed here, an element of understanding, which means you need to empower through explanation. We've mentioned the work of my working group, so I'll very quickly go through this. The first paper we did was on how did specialists in laboratory medicine view giving patients' laboratory results directly. So this is published 3 years ago, but the work is 4-5 years ago. And there was a minority view that patients should receive results, and that there were issues in quite a number of countries at that time of that happening. And that may have actually influenced the view on desirability. But the comments were made available then to patients, and about half received results, and about a quarter refused, and the others were kind of qualified. Chronic disease patients had slightly more access to results because it helped them with their management. But again, nearly 28% did not, with sometimes for the rest. Are patients interested? Well, if they could get access, as again has been referenced, the paper that we did publish this year, yes, some patients would like access. So we thought, okay, let's see what happened, and this is the paper from, last year. Do you want your results? Blue line, yes. Red, interestingly, no. I'm not sure why the Netherlands is 50-50, but it is. Quite significant country variation. I want more information. Some people think they understand the results, so it does depend on who these patients... The patients were 100 random patients selected at a medical outpatients clinic in each country. Would I like a standard description or a reference to a website? So if you take the red and the blue together, the answer is overwhelmingly yes. And would a specialist in laboratory medicine be acceptable to personalise a report for you? And usually, so the blue was yes, but no was red. So there is a resistance to, perhaps some resistance to that. Some people did not know. Would you pay for that commentary? Well, the answer basically was, with the exception perhaps of Poland and Turkey, no. So you're not going to make money at this. So it was part of the service. It was part of actually, who is your client as a laboratory medicine specialist? The answer maybe perhaps is not so much the physician, it may very well be the patient, in which case it's part of your service. Victor talked about Ripple Down. This is a screenshot from Ripple Down, where, as he said, you can look at the current results, you look at the historical results. This is the professional version for going to professionals, so it will come up with a sequence of comments which then go back to the requester. But equally well, you could see the benefits of this going back to a patient in appropriate language, and would certainly enable us, if we really want to engage directly with patients and give them that information which they desire. There are probably ethical responsibilities around that. I'm not clear what they are, and that would be something we would need to understand. So if there's a patient-focused laboratory medicine approach, will it have an impact on outcomes? Well, perhaps unsurprisingly, because there's very little been done in this area, we don't know. The only thing I could find was this study from Canada. I don't know if Holly might be familiar with it, which seemed to suggest that data was lacking. So really what this is saying is, right, come on guys, if you want to find out if this is worthwhile, get out there and do something about it. Because we really don't know answers to any of the questions. So I would say patient-focused laboratory medicine is all about educating patients so they understand why they need tests, which tests they need and when, and also, importantly, what the tests results mean. Clearly, we have to engage their clinicians in this concept. We cannot do this alone, and it's been said many times that it has to be in the appropriate clinical context. So this would be an adjunct to clinical engagement, not a usurpation of a physician's role, and that has to be very clear. And so therefore, any interpretation by a laboratory clinician has to be within the limits of the scope of practices, would be the correct phrase, I guess. Why can't patients go directly to their lab? Why have they got to go through their general practitioner? I don't know. It should be perfectly possible. Of course, in some countries, this is the way around things are done. You go to the laboratory first and then you go and see your physician. But certainly in the UK, that is not yet a possibility. But it seems to me a very sensible way to go about things, providing reimbursement is appropriately rewarded and that the requests are not, shall we say, trivial, that there's been some kind of pre-authorization perhaps by their physician. Now that could have a significant impact on the workload, perhaps, of centralised laboratories, who knows, but it may very well result in different technical roles and different clinical roles, perhaps having a more outreach approach and more outward-facing approach than we ever have had before. And there's been advocacy of this in several meetings, more to do with genomics and histopathology, to be fair. And this is where I used to finish this talk, and I used to say, well, okay guys, it's Horizon or is it a mirage? And I would like to think that from the presentations we've had the past couple of days, the feedback that's come back, that it's no longer a mirage, it's actually Horizon. And it's Horizon that we should be walking towards. And I suggest the key factors that we should be arming ourselves with are communication. We need to understand the context and availability, responsibility, what training we need, which we will hear about later from Gilbert Ringer, and the competencies thereof, and the participation in healthcare delivery. The implementation, we need to agree a process and a scope with all potential stakeholders, and that starts with the patient representatives. I think we perhaps underestimate how powerful patients can be, and I'll just sort of relay an anecdote from when we implemented HbA1c in the UK, and we wanted to use IFCC units of millimoles per mole. And everybody, that means the diabetologists, wanted to retain percent because that's what they were used to, and patients would understand percent, and we confuse the poor dears if we change things. And we convened a meeting with representatives of all the medical colleges and this society and that medical society, and a patient group from Diabetes UK. And we presented the pro and con for why we wanted to do this, and then people spoke, and one professor was saying this is going to be very terrible, blah, blah, blah. And then 4 patients stood up and said, we disagree, we want the best, we want this new way of doing things. Problem solved. So I think there is definitely a case of, if you want to do something, engage patients at the beginning to get their views, to make sure it's what they want and what they would appreciate. Clearly you have to engage their physicians and of course any institutional management. You obviously need a secure IT solution, the competencies, an escalation protocol when things go wrong, an audit trail so you can find out when they've gone wrong, and regularly review the KPIs. I think we'll maybe skip that. So what's the value proposition? Well, the value proposition I would suggest that patients are empowered, that primary care physicians have a limited amount of time, and this may be a way of relieving some of that pressure on them, and that we are in a position to be able to assist with patients' understanding, ensuring that they are better informed, and as a side benefit to us, as an improved population awareness of laboratory medicine. And the unique selling point is we have great skills in interpretation and in commenting on complex investigations in laboratories. It's a key function, and patients can receive that same service in collaboration with the physicians. And so we said the title of this meeting is The End of Laboratory Medicine as We Know It, and we need to progress if we are going to survive, and this may be a way to do that, harnessing all the wonderful technology we've heard about before. There are imaging methods which increasingly provide functional information. Proton NMR is very good at giving you biochemical information. Handheld MRIs are available. There's a laser device which has just been developed which can give you biochemical information, which is almost like a tricorder from what the technical specification said. So I would suggest that we need to establish ourselves as a knowledge management experts in metabolic information as a core service for the core user, who is the patients. And I would suggest to you, we don't have the option not to. Thank you very much for your attention.